thank you, Dr. Cameron, for inviting us to talk on the role of IMRT and tomotherapy following lung sparing surgery. So, EPP represents an highly invasive surgical option for mesothelioma and therefore is falling out of favor among some surgeons, given the severe perioperative stress, the noticeable complication rate, and the long-term decrease in performance status. On the other hand, radical pleurectomy decortication is a lung-sparing surgery that includes the macroscopic removal of the pleural layer, along with the pericardium and diaphragm if needed, with the aim to remove all the gross tumor disease. However, after both procedures, residual disease is possibly left behind, and adjuvant radiotherapy is a strategy that has been advocated. Whereas it has been shown that it is feasible to deliver high radiation doses after EPP, hemithoracic radiotherapy after pleurectomy decortication is limited because of the underlying intact lung. As you can see here in this slide, this is the traditional radiotherapy technique, and so it's very difficult to deliver high radiation dose to the chest wall without irradiating the ipsilateral intact lung. And as reported by the authors of the Memorial Sloan Kettering in New York, with this approach, the results are not satisfactory. In fact, they reported a median overall survival of only 13 months and a 2-year overall survival of 23%. And I wish to underline that the pattern of failure in these patients was local and regional. So, helical tomotherapy is a novel technique that allows the delivery of image-guided intensity modulated radiotherapy by using a dynamic delivery in which the gantry, treatment couch, and the multi-leaf collimator leaves are all in motion during treatment, and this results in a highly conformal radiation dose distribution. So this is the core of tomotherapy. There is on the top the linac, and in the bottom the beam stop and the detector to perform the IGRT. And tomotherapy is based on a slip ring technology. So before the treatment is delivered, a megavolt CT scan is acquired in the region of interest, and then by using a mutual information software or a manual image registration, image guidance is performed. After the the image guidance procedure, IMRT is delivered, resulting in a very high conformal dose distribution, and this is obtained thanks to a special multi-leaf collimator which remains closed for the majority of the time of the delivering. So we use this novel technique to deliver high radiation doses in mesothelioma patients who underwent lung-sparing surgery, including radical pleurectomy decortication or biopsy, with the purpose to assess the safety of this procedure. So the study was conducted with the IRB approval, and between October 2008 and February 2011, 28 patients were enrolled in this trial and underwent to radical radiotherapy, whereas the remaining 7 patients underwent palliative radiation doses. The median age was of 68 years. The majority of patients had good performance status. 20 patients underwent to radical pleurectomy decortication and 8 patients underwent to biopsy. The majority of the patients were in stage 3 and 22 patients were node negative. In the pre-radiotherapy PFT were satisfactory. So the target of radiotherapy, namely the clinical target volume, was represented from the lung apex to the upper abdomen to include all the areas of preoperative pleural surface, and above all the posterior inferior extent of the target included the insertion of the diaphragm, usually the high OL2 vertebral body. The interlobular pleura were not included, and the ipsilateral mediastinal lymph nodes were included only in case of N1 and 2 disease. The ipsilateral pericardium is always included, and also the thoracotomy scars. So all the patients underwent to FDG PET-CT before radiation therapy, and a boost gross tumor volume was targeted on the area with positive margins or suspect for residual disease, and all the Foci PET uptake positive. So the boost gross tumor volume was defined together with the nuclear physician. The radiation dose was of 50 gray in 25 fraction to the entire hemithorax, and a simultaneous boost up to 60 gray in 25 fraction was delivered to any FDG-avid areas or region of concern for residual disease. So this is a typical dose distribution in which, as you can see in red, there is the prescription dose, and tomotherapy allows the sparing of the intact lung by the prescription dose, and in green is the boost high dose region. Also in these slides you can see well how the lung, the ipsilateral intact lung, is spared by the prescription dose. So physicians evaluated the clinical symptoms at every follow-up visit, and this is the therapeutic scheme. 28 patients were enrolled, 10 of those underwent also neoadjuvant chemotherapy, and 23 underwent adjuvant chemotherapy, and all patients were treated with a high-dose hemithoracic radiotherapy. So coming to the results, the median follow-up was 19 months, and so all patients had a minimum follow-up of 6 months, and so they were accessible for acute radiation-related toxicity. No patients interrupt the radiotherapy because of toxicity, and so all patients completed the radiotherapy course. So 5 of the 28 patients, corresponding to 17.8%, experienced severe respiratory symptoms within 5 months after radiotherapy. So we had 3 cases of grade 2 pneumonitis and 2 cases of grade 3 pneumonitis, and no fatal respiratory or other toxicity was documented. So this is an example of radiation pneumonitis 5 months after the end of IMRT. And so this is the chest CT. And so as you can see, a dense fibrosis in the anterior and the posterior part of the chest wall, and those areas correspond to the boost high dose region area. And so you can see a case here without or minimal lung changes after radiotherapy, and in this picture, severe fibrosis after high dose IMRT. So an interesting data we found is that the contralateral lung VU5 was strongly correlated with the risk of pneumonitis. So the VU5 is the amount of contralateral lung that received 5 gray. So those patients without pneumonitis had a VU5 of 17% versus 33% of patients with pneumonitis. So from this study we can conclude saying that helical tomotherapy allows the safe delivery of high doses up to 60 gray of radiation to the hemithorax of mesothelioma patient with a lung. And the question whether this therapeutic strategy might have a prognostic impact remains to be answered. So now here we wish to answer to this question, and we here present for the first time our long-term survival results of radical pleurectomy decortication followed by high doses radiotherapy. So for this analysis, we include only those patients who underwent radical pleurectomy decortication. So these are the clinical characteristics. The majority of the patients had a good performance status. The epithelioid histology was in 18 patients. And 17 patients were node negative, and I wish to underline the fact that 17 out of 20 patients had no gross residual disease after pleurectomy decortication. And also I'd like to stress that the median follow-up was of 27 months from surgery. So coming to the survival results, the median overall survival was of 33 months, and the 2-year and 3-year overall survival were 17% and 49% respectively. The median progression-free survival was 29 months, with a 2- and 3-year PFS of 65 and 46%. The median local regional control was not reached, and the 2-year and 3-year local regional control were 82% and 59%. The predominant pattern of failure was distant, and 35% developed a distant metastasis as the first site of relapse, and only 3 patients developed an isolated local regional recurrence. So I wish to discuss a little bit with this data. Also, the author of the Memorial Sloan Kettering used this therapeutic approach, and they published their survival data recently in the Red Journal. And this table compares the 2 series, the Memorial Sloan Kettering series and the Aviano series. Both series correspond to 20 patients. At the Memorial, they use a radiation dose of 46.8 gray versus 60 gray. The median follow-up from surgery was 18 months. And the median overall survival reported was 26 months versus 33 months. The 2-year overall survival was 53% versus 70%. The 3-year overall survival was not reported, and the pattern of failure was local in the Memorial Sloan Kettering series and distant in our, and the radiotherapy mortality was similar. So the first hypothesis to explain this data are, first of all, the radiation dose. We do think that the radiation dose has a prognostic impact in these patients. Second, the adequate surgery. In fact, the majority of our patients underwent radical surgery with negative gross residual disease. And this slide is only to be used for the discussion because it represents a very preliminary results of our institute. So these are unpublished preliminary data on 64 patients treated with radical tomotherapy. And as you can see, this is the local regional control. Pleurectomy decortications followed by high-dose radiotherapy went better than biopsy-only patient followed by radiotherapy. And this advantage in local regional control translates in an overall survival advantage. And the importance of obtain a radical surgery without gross residual disease is also shown here, because these are pleurectomy decortication patients without gross tumor disease behind versus the biopsy only and the PD with gross tumor disease. And the third hypothesis is the favorable prognostic factors of our patients. Only 2 had non-epithelial histology, only 3 patients had a node-positive disease, and also patients who underwent radiotherapy to our department, which is a tertiary referral center for radiotherapy cure of mesothelioma, had surgery elsewhere. Thus, only patients with good performance status might have been referred to us. So we can conclude saying that high-dose radiotherapy following radical pleurectomy decortication led to excellent local regional control and survival in mesothelioma patients. And our results and the Memorial Sloan Kettering results can be compared with the results of other American academic centers using EPP followed by IMRT. So it's important to know that the follow-up is calculated from surgery or from diagnosis, and the median overall survival was comparable. So our data support the idea that this approach represents a concrete alternative option to EPP. Thank you for your attention.